Welcome everyone to the Project Echo. This series is about intellectual disability information and education, and it's brought to you by the West Vic Primary Health Network's SPIDER project, supporting people with intellectual disability to access health. This is Series 3, Session 2 of this Echo network. It's Tuesday the 8th of November 2022, and this session is titled Support and Treatment of Mental Health for People with an Intellectual Disability. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're zooming in from today. We recognise their diversity, resilience and ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past, present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations, and we work together to closing the gap. My name's Robert Ward, and I'm a full-time GP in Geelong, and I'm the GP facilitator for this Echo series. I'm also the father of a 24-year-old young man with an intellectual disability. And in the early years, his behaviours were distressing for him and at times overwhelming for my wife and I and our young family. Behaviours that were confronting and restrictive and isolating. We had a caring paediatrician, and a few months before my son's 3rd birthday, we started medication, which we found very helpful for our family. So I'm sure there are those here today who are listening to this podcast or listening to this Echo who have roles in primary health, who have met many people with intellectual disability who are on medications to assist their behaviours. For many, this may have been started in childhood and continued. For others, the reason for the medication may have been lost in time, and with people's transition from child to adult services, changing of doctors or moving away from the home and into the care or independent living. Our last session, we heard about the difficulties in diagnosis and defining mental health concerns in people with intellectual disability. As GPs, we're often time poor, lack specific training to find it difficult to access appropriate specialist support. We're often under pressure from parents and carers to assist in managing behaviours that our patients find distressing and are distressing for everyone around them, and often behaviours that restrict our patients' access to the community or to services, and sometimes are just plain dangerous for the patient and their carers. So in this series, we're discussing the connection of mental health and intellectual disability and exploring how best we can support our patients and those caring for them. So today we'll be joined once again by Dr. Chad Bennett, who's the Clinical Director and Consultant Psychiatrist at the Victorian Dual Disability Services at St Vincent's Hospital. And we're going to be discussing support and treatment of mental health for people with an intellectual disability. So if we just bring up the etiquette slide, and we just remind ourselves of the Echo subjects. So what we'd like to do, if you can leave your videos on, that'd be terrific. And let's drag this over to my screen over here. And we'll go around and introduce ourselves so we can all get together and when we can discuss the case later on. So the talk by Chad will be recorded for people to listen to later on, which will be a great resource for people to access. The case discussions later on won't be recorded. I just remind everyone about privacy rules and just being respectful to each other, particularly when discussing cases. That would be fantastic. So I might just go to the agenda slide. So our agenda today is we're going to have a presentation by Chad Bennett, who, as I said, is the Clinical Director of the Victorian Dual Disability Services at St Vincent's Hospital. And our panel member today, as always, we're joined by Tracy, who's a General Practitioner and the former Director of the Centre for Developmental Disability at Monash Health. And we're going to have a case presentation today by Demopoulos, who's the Senior Behaviour Support Practitioner at GenU here in Geelong. So what I'd just like to remind people, the case studies are an important part of the Echo discussions. So if you have an example of a case that you think we might find interesting or you want some help with, please log on through the QR code there, or contact the Echo via the chat tool. There's a website there, and to put in your case study, and I think they're all really good way for us all to learn. Professional development, just a quick reminder, There are some professional development opportunities, but I suspect they're waning near the end of the year, so I hope everyone's got their points. But if you want to contact the Workforce Development at Westvic PHN to inquire more about that. There is a survey. If we can fill that out, I think it's really important for evaluation of sessions. So I know the Spider team would be really keen for you to do that. There's a QR code there, or in the chat there's a contact address. Once again, we've got the learning outcomes for the session. We have to recall the terminology used in describing intellectual disability and identifying solutions to support primary healthcare professionals to deliver high quality care that is tailored to individuals. Assess the disparities in health inequalities in accessing primary healthcare for people with an intellectual disability, to recognise the United Nations Convention on Rights of a Person with an Intellectual Disability, and to, as always, learn how to implement reasonable adjustments in primary healthcare to improve the outcome for our patients. So I know we've got a lot to get through today, so I'd like to just to go through the room. We've got Whitney and Gemma from the Westvic PHN, and they'll be following on with the chat and monitoring that. We've got Chad. Do you want to just introduce yourself there, Chad, or wave? Chad's our speaker today, and he's going to be joined by Jane Tracy. Hi, Jane. We've got also in the room, we've got Kerry Robinson and Nicole Radford, both from the Spider Project. And I wonder if, John, do you want to introduce yourself again,
John,
please?
I'm a GP, full-time GP in Geelong West.
Fantastic. Welcome. Welcome again. And Michael Costa. If you're there, Michael, if you wanted to introduce yourself. Michael's on mute there, so we can catch up. And Kim, good morning.
Hi, my name is Kim Halpern. I'm a behaviour support practitioner with Gateway Support Services, and a lot of the participants I work with have complex presentations and mental health issues, and I want to learn more to be able to help them get the right supports.
Fantastic. Welcome, Kim, and hopefully we can also learn from you as well, which would be fantastic. All right, I think that's sort of everyone in the room, just a small group this morning, so hopefully we'll get some good information. And so today, Chad's going to talk about support and treatment of mental health for people with an intellectual disability. So I suppose covering what are the sort of the general principles, what are the risks for us in primary healthcare, maybe some legal requirements, and what are the different approaches and things that we should all be considering. So Chad, I might like to hand over to you.
It's a quick overview of some of the, I guess, the major treatment and management issues. Next slide, thank you. Just very briefly, I work for the Victorian Dual Disability Service, and the short version is we're happy to take calls from anyone, and we also run some online webinars if people are interested, so feel free to go to the website and find out more. Next slide, thank you. So I guess kind of what I wanted to talk about today was just some of the difficulties that you might experience in working with people with intellectual disability and comorbid mental disorders. And I talk about mental disorders because that's broader than the content of mental illness. So some people have illnesses and other people have kind of, I guess, things like autism, which we don't think of as illnesses in the same way, and they don't have an onset and they're not necessarily treatable with medication in the same way. And just look at some of the modifications to practice that can be made. Quick revision, I'm sure you're all familiar with the biopsychosocial approach, which is the major one we use in psychiatry as a way of thinking about the different approaches to both management and assessment, and just some of the principles that inform good management practice. Next slide, thank you. And within that, what we add to it is this kind of idea of a developmental approach. So it's about kind of thinking about the person's level of development and tailoring any interventions appropriate to their developmental level. So that includes things like use of language, to some extent medication dose, as well as adjusting particularly a number of the psychological interventions to be able to cater for that person's level of understanding. Next slide, thank you. So some of the general principles, and I think one of the one that's perhaps often forgotten is thinking about consent and the legal framework in which we work. And I think that's kind of the first port of call. As always in psychiatry, we're aware of the risks, and we need to think about the risks in managing this population. And a particular issue is ruling out any comorbid medical issues that might be contributing to the person's presentation. It's important to kind of like establish what the goals of treatment are, and this can vary between the different stakeholders involved in looking after someone. So people may have different views about what the goals of treatment might be, and it's important to kind of work with all of the stakeholders to have some consensus about what the goals of treatment might be, and then to establish where things are at before introducing any intervention, so you can then evaluate the effectiveness of that. And then lastly, it's about following up and monitoring. So next slide, thank you. So consent implies that I guess there's three major issues in relation to consent. The first is the person's got to be free from coercion. So in other words, it needs to be their decision and an informed choice. And to make an informed choice, they need to have the ability to understand the information that's presented to them, to manipulate it so they can understand what that might mean for them, and then to communicate their decision in relation to this. Under the Medical Treatment Act these days, it's very there are significant penalties, in fact, if it's not clearly documented who is consenting to the treatment. So certainly in our work nowadays, we're very clear about having to document who is providing consent, and this can be a guardian, either informally under the Guardianship Act, which usually, and I always find this a bit scary, apparently the person who's able to consent on our behalf, the first person is your spouse. And I think that's a good reason for always being nice to your spouse. But then there's a hierarchy of different people who can consent on your behalf. That includes parents, siblings, and it used to be quite a long list, but it's now quite short. But informally, your next of kin can provide consent. If that's not possible, you can actually formally appoint a guardian under the Guardianship Act, and other things that may come into play are the Mental Health Act. And interestingly, in Tasmania at the moment, anyone who's not able to consent, who's being treated for a mental disorder, needs to be under the Mental Health Act. So that's a bit of a shift, because it used to be under the Guardianship Act, and it's caused all sorts of administrative and bureaucratic kind of issues. And then there's often a range of services that we have to work with. So these might include some of the remaining disability services, so disability justice, the NDIS, as well as mental health services. Next slide, thank you. So that was a bit about the consent issues, and then just very quickly about risk. And in general, the kind of risks that we think about are the same as for the normal population. So we think about suicide, we think about self-harm, we think about violence. But in this population, there are slightly different patterns of risk. And these relate to some extent to the level of IQ, but there is, although there is a risk of suicide, it seems to be lower than the general population, and this is probably related to ability to access ways of committing suicide, as well as the conceptual kind of tasks involved. There's also a lower risk of serious violence, including homicide, but there's probably a higher risk of actual violence, which is often undocumented and often doesn't result in charges. And this is often a reason for someone being referred to services. There are high rates of self-harm, but these aren't always the same type of self-harm you might see in the normal population, which might involve, for example, cutting. This includes things like skin picking or head banging, or these kind of repetitive injuries that you sometimes see in people with autism. It's important to think about vulnerability to abuse, and the abuse is fairly common in this population compared to the normal population. And then the other risks you see are those of discrimination and exclusion, and higher rates of, in fact, I think one of the interesting things about this population is they die 20 years younger than the rest of the population. And one of the commonest causes of death is actually choking, which is related to some degree to antipsychotic medication. So there's a high risk of medical complications, and to some extent, this can be iatrogenic in relation to the medications that they're commonly prescribed. Next slide, thank you. So the approach in the UK is one, the title of it's called this idea of reasonable adjustments. So it's what adjustments you can make to the way that you work with someone to account for the presence of an intellectual disability. And some of the things they talk about is being aware that the person has a disability at the point of entry. So it's one of the things that's screened for before the person actually attends the surgery. And having a slightly, given the health issues that this population has, the difficulties they have in accessing services, having a lower threshold for service provision. One of the things that we're certainly keen on in mental health services that we've not yet achieved is having data collection, so we're aware of how many people are presenting to services with intellectual disability and what happens to them. Having guidelines and policy, and interestingly, none of the mental health services I know of in Victoria at this point in time have any specific policies in relation to people with intellectual disability. So there's a range of policies in relation to dealing with people, for example, from Aboriginal and Torres Strait Islander backgrounds, as well as other cultural backgrounds, but not at this point in relation to intellectual disability. Interestingly, it's looking like the new Disability Act will require all public services to have some kind of policy in relation to this population. And then there's thinking about how you might work with other service providers, and particularly in some individuals, it's about having a fairly tight kind of framework about when to, for example, involve the police, GP, local area mental health service, police, ambulance, and other services. Thank you. Next slide. Thinking about how people might be able to access the service, whether they're continent, for example, whether they need wheelchair access, whether there's enough room for them and the staff, what the waiting area is like, how that might affect people with sensory issues, so bright fluorescent lights, noisy environments might make some people quite stressed and might make their behaviour worse. One of the things we try and recommend is having a time where people aren't going to have to wait. So usually the first appointment in the day, the waiting rooms are less crowded. At that stage, usually people can come straight in and have their appointment straight away without having to wait around for too long. It's important to think about where you're going to get the information from. And so a fairly common kind of event is that the carers will get someone in specifically to take that person to the appointment, but they may know nothing about the person, and the person themselves may not be able to provide you with a history. So it's important to think about where you're going to get the information about what's happening, and to think about how you're going to communicate with them, and thinking about the risks in terms of them being in a surgical setting or a clinic kind of setting. Next slide, thank you. So that's a bit of background stuff, and then we'll quickly talk about some of the specific therapies. And by biological therapies, we're primarily talking about medication. Next slide, thank you. But it's always important to exclude any physical health concerns. And I think one of the really difficult bits about this is kind of, you can do the routine health screening, but it's about how far do you push this screening? Do you have to push it to the extent where, for example, if someone's not cooperative, are you going to anaesthetize them so you can do a proper physical examination and get the bloods? And it comes down to how strongly you suspect there might be some kind of medical problems, and the severity and nature of the type of behavior problems or other problems that the person's presenting with, as well as their ability to report on any physical health problems or pain that they might be experiencing. So the first step, and this goes needs to be under review, is to consider any physical health concerns. Next slide, thank you. So in thinking about medication, there's very little evidence in relation to specific medication and treatment for people with intellectual disability. In fact, the evidence, most of the trials, what they have shown is that people with intellectual disability receive high rates of psychotropic medication, often polypharmacy. It's often unclear why they're being prescribed it. In other words, are they getting prescribed for a behavior, or is there a diagnosis of a specific mental illness? A lot of the prescribing is off-label, and often consent hasn't been gained for this. Often you find that they're prescribed medication for a diagnosis of schizophrenia, for example, but then they usually don't follow the usual treatment pathways. So if someone, for example, is treatment resistant, it's much less likely they're going to have those kind of more effective treatments such as clozapine, ECT, and lithium, despite there being no evidence for exclusion. And there's a range of difficulties in terms of making diagnosis in this population that make the use of medication problematic. And we kind of talked about those in the assessment workshop, so I'm not going to cover those here. Next slide, thank you. There are some specific considerations in people with intellectual disability. There are risks of the medication having untoward effects because of underlying brain issues related to the cause of the intellectual disability. So if someone's got cerebral palsy, for example, it can affect people, particularly the antipsychotics, and can affect people's cognitive function and make the pre-existing cognitive deficits worse. Problems like epilepsy are pretty common in this population, and a lot of the psychotropic medications can exacerbate epilepsy, and there are issues in relation to interactions between the different medications. Weight can be a problem prior to starting any medication, and many of the psychotropics increase the risk of weight gain. And you also see these kind of odd responses. So you see atypical responses to medication that you don't necessarily see in the normal population. And a particularly common one is with the benzodiazepines. You can see this kind of paradoxical excitation kind of response as opposed to a sedative response. And then lastly, one of the things we find is often the patients don't know why they're taking medication. They're uninformed about the side effects. And often the carers know very little about the medication and how to monitor side effects as well. Next slide, thank you. And that particularly applies to PRN medication and the use of PRN medication. One of the things that research demonstrates is that people with intellectual disability often experience side effects. It's often unidentified because they may not recognize side effects. They may not think about informing other people. Some of their pre-existing deficits may mask some of the, for example, extrapyramidal kind of side effects. And it's difficult to work out what's a side effect, what's related to the medical problems or the psychiatric condition. So you might see depression and withdrawal and sedation, and it's difficult to tease out which of these elements of a presentation is related to medication or the pre-existing deficits and medical conditions or psychiatric conditions. Next slide, thank you. So the rule of thumb is that, generally speaking, we should only be prescribing psychotropic medication when a specific diagnosis has been made, or when in some cases when you think there might be a psychiatric disorder, but you don't really have sufficient information to make a formal diagnosis. And then lastly, challenging behavior in the absence of a diagnosis, just under certain circumstances. So ideally, you make a diagnosis of depression and you treat it as for depression for the normal population. Sometimes in people who are non-verbal, they're not going to meet the diagnostic threshold. So you can try an antidepressant, but it's a trial. And if it's ineffective, then you stop the medication. In some cases, when all measures have been tried to control a behavior, it's reasonable to try a psychotropic medication. But before doing that, it's very important to establish a baseline, to establish what the goals of treatment are, to establish a monitoring framework and a timeline for it. And then you can try medication, and if it's been effective, then it's reasonable to continue. But if it's not, then the medication should be discontinued. And often what we find is that it's continued. There are requirements under the Disability Act to report medication when it's used to treat behavior, but not if it's used to treat a specific psychiatric disorder. Next slide, thank you. So it's important to be clear about why a medication is being prescribed, to get consent, to review the impact of this at each review, and to think about drug interactions. And so those are the kind of very simple guidelines in relation to prescribing. Next slide, thank you. So that's a bit about medication. Then I think the bit that we tend to forget about is the kind of psychosocial interventions. Next slide, thank you. And I think kind of one of the difficult bits is that the way medication works is very complicated, but it's actually very easy to prescribe medication. And so often we end up prescribing medication. Whereas if you think about social factors, they're actually very simple to understand. The difficult bit is actually in the implementation of social interventions. And if you think about your own lives and you think about what's important in your own lives, it's kind of friends, family, good health, having a role, having satisfaction in the things that you do, leading a healthy lifestyle. And it's important to kind of try and, if you like, engineer those kind of things in people's environment so that they can achieve those kind of things. And there's a variety of different ways of or different headings, I suppose, that are in this slide that you can kind of think about. But it's about thinking about someone's health in that kind of broader context, rather than just thinking about illness and medication. And often what we find is that people are bored, the type of activities that they're engaged in are inappropriate for their age level, for their level of function. They're put together with people that they don't necessarily like. They don't have the opportunities to form their own relationships and to maintain those kind of relationships. And then there's issues around sleep, diet, being prescribed drugs, having money and assistance to engage in kind of more meaningful activities. So I think it's really important to think about these factors in the context of someone's life when thinking about why someone might be behaving in a particular way. Although it's very difficult to engineer change to try and facilitate these kind of development of these kind of issues. Next slide, thank you. But if you can, you build confidence, you build resilience, you improve people's quality of life, you improve their well-being, and you can reduce the symptoms and impact of mental disorders. And as I mentioned, there's a number of difficulties and barriers in implementing these kind of interventions, but I think it's an important focus in thinking about addressing people's mental health issues. Next slide, thank you. Then lastly, I think it's important to think about the range of psychological therapies, and we tend to think about behavior management strategies, but in fact there's the range of strategies that we might think about applying in the normal population can also be applied to various degrees in people with intellectual disability, depending on their degree of intellectual function and capacity to understand and make use of these kind of therapies. Unfortunately, they're often excluded from them on the basis purely that they have an intellectual disability. And I think the other interesting bit about working with this population is you also have the opportunity to work with them in a different way. So in people who are non-verbal, you can look at working with drama therapy, role play, music therapy, sensory integration. And so you can kind of introduce these therapeutic modalities that we don't necessarily have the opportunity to use in the normal population in the same way. Next slide, thank you. And so the indications, I guess, are the same as for people without intellectual disability, and it depends on what's available, what the diagnosis is, what their willingness to engage in therapy. And I think one of the key points in this, and this is applicable to any psychological therapy, is it's about motivation. And too often we see people are dragged to psychological therapy without them really understanding why they're going or really having any significant desire for change. And it's like giving up smoking. If someone's not really motivated to engage in psychological therapy, it's unlikely to be effective. But in applying psychological therapy, it's important to think about how complex and what modifications may be needed to make to apply any psychological therapies. Next slide, thank you. And very quickly, there's a long history of applied behaviour analysis in this population, and this can be applicable both to the normal population and people with intellectual disability, and is based on learning models where it's essentially trying to determine what people's motivation for a particular behaviour might be by looking at the antecedents and the consequences of people's behavior, and build up a very clear picture of when the behavior occurs, and on the basis of this to then kind of implement strategies that enable people to have their needs met without having to behave in a particular way. And so it might be a need for communication, it might be a need for social interaction, or because of meeting basic needs such as sleep or food. And there's a long history of kind of this mode of treatment being applied in people with intellectual disability. It can be effective when it's used. We've moved more to this concept of positive behaviour support. Next slide, thank you. Which uses the principles of applied behaviour analysis, but is more person-centered focused, avoids negative kind of approaches, helps to build up skills, looks at people's quality of life, and is informed by a functional behaviour assessment, but is a broader approach than just a simple looking at the function of someone's behaviour. And again, there's quite good evidence for the effectiveness. One of the things I would say about both applied behaviour analysis and positive behaviour support is that they are very difficult to implement. Again, they're quite simple concepts, but it's actually quite difficult to implement consistently and effectively. Next slide, please. And this is just an example of how you might approach someone with a positive behaviour support strategy. So it's thinking about the kind of settings that it occurs in, so the sensory issues related to noise, environment, other people, what the purpose of the person being there is, looking at positive programming, so helping develop general skills, so people's ability to communicate, people's ability to be more assertive and to let people know when they're not feeling right, teaching them equivalent behaviors, developing anxiety management and anger management techniques, which are general skills that people can use in a range of treatments before looking at those kind of more direct treatment of a specific behavior that adopts that kind of more behavior management kind of approach of antecedents, behavior, and consequences. And then within that, it's always important to have strategies available for when someone is behaving in a particular way that puts both themselves and others at risks. Because I think one of the really simple rules is unless the staff and the person are safe, it's very difficult to move forward. Next slide, thank you. So I've probably talked about these, and these are the indications for psychological therapy. And I think one of the things that's often missed is that people, and this applies again to the normal population, is that people need to be able to sit and tolerate talking about quite difficult issues. And I call this being psychological minded. So it's about the ability to reflect on past behavior, identify and link thoughts, emotions, behaviors, and events, and how that might be then associated with outcomes. Because if you don't have that ability, it's difficult to then think about how you might then change your behavior. Next slide, thank you. There's a number of barriers to all sorts of therapeutic options in people with intellectual disabilities. So there's limited funding available, there's limited Medicare rebates. People tend not to think of engaging people in psychological therapy. It often takes longer, needs to be simplified. You ideally have psychologists who are more experienced at working with this population. And there's the concern that actually kind of people with intellectual disability may not respond to treatment, whatever is provided, and so they don't get it in the first place. Next slide, thank you. And then lastly, it's about putting all these different elements together, and it's about working with the system to be able to provide therapy, social interventions, psychological interventions, crisis interventions, and working together, I guess, and this can be difficult within different service structures, to identify goals that are shared across the different settings. Next slide, thank you. Just to quickly summarize, I think in dealing with this population, it's important to adopt a comprehensive kind of approach, and to recognize the difficulties they have in accessing appropriate mental health care. And often mental health care is a substitute for what I would call difficulties in achieving a satisfying and fulfilling kind of life. And I think that is the last slide. Then there's a whole series of references if people are interested. And that's the end of the presentation.
Thanks, Chad. I mean, it's a really important and really difficult subject, isn't it? And I suppose as GPs, we're often faced, excuse me, with patients that we've met at all stages of their life. Excuse me, we're not always privy to why they've been put on medication in the first place, and that sort of story's got a little bit lost on us. So it's been great to have that background. Jane, you've put some wonderful comments in the chat. Do you want to elaborate on any of those?
Well, just to follow up on what, thank you, Chad. That was just a terrific talk, and it's just so important to think about that holistic approach to mental health, not just focusing on the medication, because it's just too easy. We've got our script pads next to us, and it's an easy, quick solution, but it's actually not a solution at all. And very often, the contributors to disorders of mental health are the person's social and the experience, the environment in which they live. I'd just like to follow up on the deprescribing and the thinking about the medication review, I suppose, and reinforce Chad's point that people are on antipsychotics very often because somebody has put them on for behaviour in the past, and then there's an assumption made by future medicos that because they're on an antipsychotic, they must have a psychotic illness. And we've got to always check that, and that can be difficult to find in the history, the indication for the original prescription. And so sometimes it's a trial of deprescribing that's required, but so important. I heard about a patient just yesterday who was has been essentially asleep for 16 years because of the huge doses of antipsychotic and benzos that he has been on for his behaviour. And, you know, it's such a tragedy that you're taking somebody's life from them when they're so sedated. And very often the cause of the original behaviour change is something that was in that person's environment. So people are often on antipsychotics for no good reason, and there's a kind of a medication spiral once they're on an antipsychotic, and then there's a behaviour outburst for whatever reason. Maybe somebody's anxious or something's changed in their environment, or they're unwell and they're in pain, but their behaviour escalates for some reason, and the dose of antipsychotic is put up. And then that might happen again a few months or even years later. And then the dose is put up and it's put up and it's put up over years and years and rarely decreased. And so when we come across a new patient, we need to be very critical in our thinking and think, why is this person on this medication, and do they need the dose that they're on? And so be active in our management. And I guess the other thing I'd like to reinforce is what Chad said again, that behaviour change is a blunt kind of response to a range of contributing factors. It's certainly true somebody may have a disorder of their mental health, but it can also be a reflection of physical pain, distress, discomfort, and it can be a symptom of changes in the person's environment, or indeed grief and loss. And so thinking more broadly about the way behaviour, of what the behaviour is meaning for that person, is really an important start, because effective treatment depends on accurate diagnosis.
Thanks, Jane. Does anyone else have any other questions for Chad there?
The only kind of quick thing I'd quickly add to that, there is also one of the problems we've often seen is that people often get worse when you stop the medication, particularly if they've been on it for a long period of time. So I wouldn't advise jumping in there and just stopping people's medication either. It's a real catch-22. That the trick is not to start people on medication. Once they're on it, you've got to be quite cautious about withdrawing it. And there seems to be a kind of withdrawal effect, particularly to antipsychotic medication. So we're kind of talking about this. Everyone knows about the movement disorder that's seen with long-term use of antipsychotics when you withdraw the medication. There's some evidence for a long-term kind of like behavioural kind of consequence of antipsychotic medication as well.
So it has to be very slow and considered, but also sometimes that behaviour changes because people are waking up. And you know, there might be a spike in behaviour while you get their life sorted out a little bit better. What brings them joy? What brings them peace?
And often the GPs at the forefront of that, because we've been asked by people, you know, by disability support workers who bring patients to us to do a quick medication review, and that medication review isn't really a medication review. Often it's a signing off on a drug chart that's just been added or just been continued in perpetuity, really. So Zach, I understand
right.
We've got Zach there from GenU. Zach, I understand your case study didn't quite fulfill the brief today, so which is probably good because it lends us into a little bit of discussion, gives a bit of time to discuss Chad's presentation, if that's all right with you. And probably, so Zach, you're a positive behaviour support person. So what's sort of your role, and how can we sort of access your sort of support for our patients? Because that seems to be, you know, really important.
Okay. Hi, everyone. So I'm Zach, and yes, it's true. I missed a vital component of the brief, which was the presence of intellectual disability. Talking about from API much later in life, so it's a bit different. Anyway, I got him confused with someone else who was very, very similar, but who actually does have an intellectual disability. But that's all good. yeah, so I'm from GenU, but there's a lot of providers around, NDIS providers who provide specialist behavioural intervention support, which is the full technical name. But essentially, positive behaviour support is kind of like the endorsed practice model that sort of underpins most of the frameworks that the NDIS sort of espouses. You'll probably find between providers there's a lot of differences in their, I'd say, clinical leanings. Some are much more heavily, for example, ABA based. Others probably a bit more comprehensive and holistic, I guess you would probably say. So anyway, to access behaviour support under NDIS, you need to have an NDIS plan, is the first thing. Eligibility is that someone is presenting with behaviours of concern, and there's a definition for that in the Disability Act, but essentially it's any behaviour that's causing or is at risk of causing harm to the person or others around them, or exclusion from the community in some way. So as examples for younger kids, a suspension from school or community programs, after school care or whatever, because people can't sort of manage the behaviour or keep others safe, keep them safe, they have the skills and so on. For adults, it might be work, it might be that they can't go to day programs, or they're kept excluded from the community, or they need to be supervised or whatever. And the other eligibility criteria would be that they're subject to some kind of restrictive practice. And so one of the ones talked about today was chemical restraint. Essentially, the medications, they're primarily designed to influence behaviour and not for treating diagnosed conditions. But there's other ones as well. There's 5 that the Commission regulates, like seclusion, being locked away in a room, environmental restraint, things are locked. You can't get into your own property or cupboards, all that kind of stuff. Physical restraint and mechanical restraint, so splints to stop yourself from self-harming. Lots of different examples. But if people want to access behaviour support, essentially what someone would need is that behaviour support funding in their plan. And if they don't have it, what help other professionals can do that are working with them is to identify one of those 2 eligibility criteria and to recommend it. If there's restrictive practices being used in response to behaviours of concern, it's basically a legislative requirement that they get behaviour support funding. So there's really no 2 ways about it. You just have to identify those pretty much, not a long report to say that someone's subject to restraint. And then they will get inclusion. Sometimes NDIS funds a small amount of funds for a more comprehensive assessment from a service like ours, and we would do a more comprehensive assessment of the severity or impact of the behaviours, the restrictive practices that are in place, the kind of things we think that might help, how much involvement we think we need, and then we give that to the NDIS. They fund it a bit more if we meet the criteria, and so on. So all the things that Chad was talking about pretty much summarises most of our service. And like you said, it's pretty broad. The hardest part is implementation. It's easy to, well, I can't say it's easy to identify, because sometimes we get cases handed to us where there's obvious precipitants to the behavioural perpetuating factors which haven't been identified. But, you know, identifying the issues is one thing, but then bringing a team together and getting everyone to work on the plan and actually follow it through is another issue entirely, which probably take up half of their time. So yes, it's definitely true that it's hard to implement, but it really comes down to sometimes not even clinical aptitude, it's the teamwork and other professional qualities that will make things work. So Robert, one of the things you mentioned in the in previous things, and I liked your presentation at the, I keep wanting to say summit, but it was the AGM recently, was just that kind of fragmentation in care teams, those siloed approaches to care teams and how troublesome that is. And so it can be hard to find practitioners sometimes who focus on bringing everyone together and making sure that everyone knows their roles and so on. But yeah, so essentially those are the eligibility criteria to get someone in. You can identify those, write a quick letter and give it to whoever the person or their nominee or their support is, and just say, look, this person could benefit from behaviour support and here's why. So yeah.
That's great. Thanks, Zach. And I suppose as GPs, we do get that siloed approach because we are maybe hard for you to contact, and we often don't know who you are Even care providers for our patients, often can't identify the behavioural support personnel or the allied health that are looking after people. So it'd be nice to keep a record of that for GPs to contact. Do you find GPs are hard to contact?
It depends
Yes.
on. It probably depends on who they are, really. Some are. I don't know. I feel like some people just don't try to contact GPs. Maybe they're a bit daunted by the administration or whatever, or don't know their contact details. They don't know where they practice. They don't know how to Google where someone works, or whatever. But then other times, some people, it's a bit of a communication delay. But yeah, I mean, it just depends. Some GPs are very proactive, so it probably just depends on the practitioner, really.
Yeah.
Well, can I ask a question? This is probably a terrible question to ask at 8:25. But listening to Zach talk, so NDIS, I've got a really big problem with understanding NDIS as an experienced GP, and I struggle with this all the time. So someone comes in, someone's got an NDIS funding and plan. So who is sitting there deciding how that plan's gonna look, who's gonna be involved? And presumably is there a central cog person in that person's plan that presumably works with the family or the guardian or whoever it might be as to what the big picture management's going to look like? And then my reason for the question, shouldn't that person who's maybe at the center or the hub of that have a pretty good idea who the medical team is? Because I must say, as a GP, I really, really rarely get any input from NDIS per se, or a management person, or I see it as utterly fragmented, I must say. And again, it's a terrible question at 8:27. I'm sorry, but that if you could have a whole week or a whole session on this, I'm sure, just to get some sense of how this works. That's just a comment, maybe.
Yeah, and probably to John, in a fortnight's time, our session will be more focused on this, and Zach will have a little bit more time, I think. In a fortnight, the subject's going to be about behavioural support, so it may help answer some of the things then. But yeah, look, I certainly find it quite frustrating with that.
So I find the key person is the NDIS support coordinator, who's the person who controls the funds. I'm not sure, and certainly if the person then needs more funds, that's the person who then kind of goes and tries to seek them. But but the way to think about them is that they really control the purse strings. They're not like a case manager. So that kind of role's disappeared. So
who's deciding whether that money goes to Zach, goes to OT, goes to whatever, liaises with the GP perhaps? Who is that person at the hub of the management overall plan? Because there's huge sums of money with some of these plans, I know.
Yeah. John, they go through a rigor to actually develop a plan and get the evidence that's required that says that a person would have a plan and what's required or needed in their plan. It can be a costly experience, particularly if it's a person with elements of autism, because that has to be proven. And then once that there's a definitive diagnosis, there's then a plan is put forward saying what sorts of supports or therapies that the person might need, and then that goes to NDIS and they make that decision. And there's often been some challenging decisions made because of the conflicts or tensions between what people believe is required from the person's perspective and their supports, as opposed to what NDIS actually fund at times. And often if the funding isn't used, you lose it. And it's like, well, hang on a minute, what if you actually can't get access to those professionals that's needed? So there are some definite challenges in relation to NDIS, which has got better over time, but it's still a beast, to be perfectly honest with you. Look, we're happy to factor in some discussion around NDIS, and along with that, MBS items as well, around people with a disability and items that GPs can use and other health professionals, particularly to look at a coordinated response. And within that, we'd like to see that if a person does have an NDIS plan and therapists and other supports in there, that the GPs and other treating professionals are involved in hearing and understanding that with that person's permission as a coordinated response to them and their lifestyle and what that looks like. So that's actually in the Spiders next training sessions that we're going to do in the future, which is coordination and learning how to maximise those outcomes, but also develop templates so that people like yourself can be involved and understand what the person actually needs on an annual basis. So based on that annual assessment and also based on preventative health care, so that we can get on the front foot. And I think that that will also help inform the sorts of resources that are required for that person through NDIS, including behaviourist tools as well through behaviour therapy. So
thanks,
that's
Kerry.
helpful. But hang on, it will come. No worries.
We're sort of really approaching, as John said, we're approaching 8:30. We're almost probably past it now. So I'd just like to thank everyone for their time today. I'd like to remind everyone about the health pathways, where we can log on through the Westvic PHN health pathways and maybe get onto some extra support there. I'd like to just acknowledge the Spider team for the great work they're doing. I'd like to remind people about case studies, making sure the person has an intellectual disability to do that. And so because that can add to our discussions. There's an evaluation slide there, if we can do that. Now, our next session's in a fortnight's time, and we're going to be talking about positive behaviour supports for people with an intellectual disability. And our presenter for that will be Adam Lyons, who's the Director and Behavioural Support Specialist of the Lancaster Consulting Australia. And we'll once again be joined by Jane Tracy, and Zach is going to join us again for further discussions about that. So once again, I'd like to thank Chad and Zach and Jane and everyone for joining us, and hopefully you have a wonderful day, and we'll meet you all again in a fortnight. And thanks for caring. Bye-bye.